Hi, everybody. This is Lisa. It's not letting me start my video, so I think it's because my laptop is connected. So I'm going to try that one. Can you hear me okay, though?
Yeah, we can hear you.
Okay, great. Okay, yeah, that's what it is. Okay, that's weird. Normally I can use my external video, so this is going to make it a little bit challenging to see the slides myself, but hopefully we can make it work. How's everybody doing? Cool. Well, thanks for being with me today. Before I get started on talking about deafness and hearing, and we have the lovely Samantha Redmond, who's going to be joining me as a co-presenter today. So thank you, Sam, for doing that. And she conferred with me on the slides and added some cool slides, so that'll be nice. But before we get started on that, you probably, or you may not remember that I also help with the Community Learning Project, or the CLP, both option 1 and 2. And I've talked with a few of you about your projects, and I think there may be some questions about what exactly needs to be done. So I wanted to just have open questions right now, and also kind of just give you a little bit more information about it that can be helpful. So if you're doing option 1, which is the direct service hours, hopefully you have been able to do your hours without a lot of cancellations. I know there have been some cancellations, but if you are struggling to get hours and you think you need to do a different site, please contact me by email, because there are other agencies out there who still need help and are still operating. So we can most likely find another place for you, or figure out another way for you to get those hours remotely. So please do let me know if you're having trouble with that. Hopefully, if you have been doing those hours, you've been noting them on your hours sheet and having them signed off. So if you haven't, you might need to backtrack a little bit and just take care of that. There is a sheet in Canvas from, it was in there last semester, and I put it in for this semester too, under the assignment tab, that has that hour sheets if you haven't done it yet. So you'll be able to find that. And then the only other thing that you need to do is a little reflection paper. And it's not a super formal paper. It's really just meant to be kind of what you have learned from working with the agency, and reflecting on what you've gotten out of it, and anything that you have to say, you know, about the agency and the mission that they provide. And that can be a 2-page, most people do 2-page, up to 3-page, just reflection on your experiences over the year. And then you're done, and you'll turn that in on by April 14th, or whenever you have your hours finished and you have that reflection done. If you want to check it off your list and get it to me sooner, I'd encourage you to do that. It gets uploaded in Canvas, and there's a little assignment link for option 1 where you can upload it. If you scroll down, it's way down on April 14th, so you don't see it down there for a while in the list. So any questions about option 1? Anybody? I'm not sure if I can see the chat. I've got too many, I'm operating with too many screens here. Okay, so for option 2, this is the one where you're learning about a community agency, and you do the presentation for them. You learn so that they can learn about land, you learn about them, and then you put together, we call it a poster, but it's not physically a poster. It's really literally just a slide that is like a poster format, if that makes sense. But you'll just present it on April 14th when we're talking about the Community Learning Project. And you'll tell us about the agency or the project that you did, what you learned from it, what they learned from LEN, and just things that you'd like to inform the rest of the group about that project or that agency. And there's a template for it. So when you do the template, you're not going to go have it printed or anything like that. Literally, you'll just present it as like a single PowerPoint slide to the group. And then there's like a one-pager fact sheet or brochure that we want you to put together that you'll turn in as well. And then that will just be a brief presentation on April 14th. So any questions about option 2? Are we good? All makes sense? Okay, if you come up with any questions later, please just let me know by email, and I'm happy to help anytime. Okay. All right, well, let me share the screen now. Okay, so it is absolutely my thrill to be able to talk. Now, are you guys seeing this? I'll need someone to talk because I can't see you at this moment. Can you see my slide presentation, or
We
are you
can
now?
see your slides,
Yeah.
but they're not in presentation mode.
Okay, get rid of this. Yeah, it flipped over to, let's see. You would think after 2 years of this, I'd be a little bit better at it. How about now? Is that now in presentation mode?
Yes,
Okay.
that's great.
Cool. Conquering Zoom as we go. All righty. So,
Lisa?
yes.
I am so sorry. I just thought of a quick question and I thought it would be easier to ask before you got started, if that's
Sure.
okay.
Absolutely.
For the CLP project, does each member have to do, like if we were to do the PowerPoint presentation, would we each do one or would we do it together?
So if you're in option 2, there should be only one member doing that particular option.
Oh, okay.
So everybody does theirs individually.
Okay.
Yep. For option 1, what's worked well in previous years is when we've had more than one student working on a particular agency, because you'll say in option 1, you'll say a little bit about what you did as well as, verbally a reflection. You're not going to present anything. Like, for example, last year with Special Olympics, we had 3 people doing Special Olympics, and they kind of talked as a group about that experience, and that worked pretty well.
I was going to say, I'm in Special Olympics with another person, so that helps. Thank you.
Perfect. Yep. And I think Be Well, and there's Art Museum, there's a few others where there's more than one person. So feel free to put your heads together and you can kind of do a group reflection.
Great.
Okay, perfect. All right, so we're going to talk about hearing loss and deafness today. So here are some of the learning outcomes that we'll talk about. Just how common hearing loss is, what some of the signs and symptoms are so that you can recognize it, even though you're not an audiologist, and also discussing what capital D means to someone who's deaf. So hopefully you'll be able to define that by the end. And then when we talk about bicultural and bilingual, what does that mean for deafness? And then a more practical topic, what are the needs that kids have for early intervention? And if they have just additional disabilities in addition to hearing loss and deafness, which happens about 40% of the time, you have hearing loss plus something else, then what are their needs with the additional disabilities and the impact? Okay, let's see. There we go. So just a few facts. Hearing loss is actually the most common disability at birth. Would anyone want to take a guess what the most common is? Or hearing loss is the second most common, excuse me. We used to say it was the most common, but now there's one more common. Could anyone take a guess what the most common birth defect might be? Any ideas? It's actually congenital heart anomalies. And we only know that now because they're screening for heart anomalies. And the same thing happened with hearing loss and deafness. We knew it was pretty common, but once we started screening for it, we learned how common it really was. Although it doesn't sound very common, about 3 babies out of every 1,000 are born with permanent hearing loss, but still that's more common than Down syndrome or cleft palate, more common than many other disabilities that are present at birth. Not as common as autism, but we don't know about autism at birth. And it's also a fairly expensive disability to work with in the schools. So, and these are kind of older figures. It's hard to keep up to date on these figures because they're not published every year. But over a 12-year period, more than $400,000 per child is spent on special education and the intervention that's needed. So how do we detect hearing loss and deafness? Well, the best way is through newborn hearing screening, and that's a universal program. It used to be that we screened babies who were at high risk, mostly those that were born and had to go into the NICU. So when I started out as an audiologist, we were screening babies in the NICU. Actually, I was able to start the program here at Christ Hospital way back, but we learned that we were missing at least half the babies because many babies that are born with hearing loss and deafness have a genetic cause. It's not due to just premature birth, but premature birth is the second most common cause. So we learned that we were missing a lot of babies. So there were the first efforts more than 30 years ago to try to push for universal screening because there's no way to detect hearing loss without testing for it. What typically would happen otherwise is that a child would show up at age 2 or 3 years not talking and being, appearing to be developmentally delayed. And I come from the era where we actually saw kids who had been institutionalized as having intellectual impairment who really had hearing loss. And I've seen a number of children misdiagnosed with autism during my career who actually had hearing loss. And so if we don't test for it directly, we don't know about it. So any child who shows up with speech language delay has a potential for hearing loss and needs to be specifically tested, referred to audiology as part of their developmental assessment. And of course, you all have been learning about that through ITT. And Sam was telling me you've had 1 or 2 children this year who either had hearing loss or were suspected of having hearing loss. So if we don't find it early, unfortunately, we end up with a permanent speech and language delay that affects every area that a child needs to grow and develop in with regard to education and social skills. Emotional skills really depend a lot on how we communicate with each other. And if that communication is cut off, it has a really profound impact on a child's life. So this was federally mandated across all states starting in the 1990s. And so now it's present across all US states and all territories. So even in Guam, Northern Marianas Islands, they are screened for hearing loss at birth. It's also the case in most developed countries, certainly in Europe, Canada, Australia. Most babies are screened for hearing loss, but it's not necessarily universal like it is here. So newborn screening is normally done by nurses or technicians, can be done by audiologists or audiology students, but usually it's done automated screening, pretty quick process by a technician. And then if they don't pass, then generally they are tested in an outpatient basis with a diagnostic test called an auditory brainstem response. This is one where electrodes are placed on the baby's scalp and it's non-invasive, easy for the baby to go through. They can do it during natural sleep. And this tells us how much hearing loss is there, what type of hearing loss is it, and whether or not it can be medically treated or might need hearing aids or cochlear implants. And Sam will talk with you later about the treatment with hearing aids and cochlear implants. And I should have said, but anytime, raise your hand if you have a question. You don't have to hold it. We can talk about it as we go. So there is a wonderful group called the Joint Committee on Infant Hearing, or JCIH, and they're an interdisciplinary group. So it includes the American Academy of Pediatrics, the American Speech and Hearing Association, American Academy of Otolaryngology, those are the ENT doctors, and the American Academy of Audiology. And all of those groups endorse detection and intervention for infants with hearing loss. And there are interdisciplinary state organizations called EDDI programs, or Early Hearing Detection and Intervention programs, that manage this. Normally that's done through the State Department of Health. So I've served on the EDDI group here in the state of Ohio for the last 5 years on their newborn screening advisory task force. It's a wonderful group because it includes parents, it includes deaf adults, audiologists, speech pathologists, physicians. Dr. Susan Wiley is currently co-chairing that group. So it's a really fabulous group that all tries to work on our systems to improve them for newborn screening. So the principles of EDDI are that all babies should be screened before 1 month of age. Here in Ohio, that's done in the hospital. The reason it's done in the hospital is that that is the best place to catch all babies. Once they're discharged from the hospital, it can be really hard to catch them. And it's really difficult for pediatricians to do this screening in their offices because they have to buy equipment, get people trained up, and it can be too late because one of the common causes of hearing loss is neonatal infection. And some of these infections, if they're caught early, can actually be treated. So it's better if we screen at birth because that helps with early treatment when it's possible. So if the baby doesn't pass screening, then they need to have diagnostic testing by an audiologist. We do that here at Children's at all of the locations to make it more accessible. But if people live in rural areas, it can be hard for them to access the care. Generally, they need to go to a hospital that has audiology services to get that care. So if they don't pass, they need to have that test before 3 months of age so that they're diagnosed. Sometimes it takes multiple visits to get the diagnosis done. Sometimes they can have fluid in the ears, and it's a matter of kind of watching and seeing if that dissipates before treating for it. If it doesn't, then they can get treatment from an ENT doctor. And sometimes they have both fluid and they have a permanent hearing loss, so it can be a little bit complex in such cases. And sometimes they can have like a middle ear problem that's due to a structural problem, not just fluid. So sometimes if you hear about newborn screening, or if you have a baby yourself and they get screened, sometimes you might be told, oh, it's probably just fluid, don't worry about it. We really try not to say that message because while it's often true, it can give people a false sense of security and they may not follow up. So we really try to just tell them they didn't pass the screening, they need to go on for a diagnosis. We don't know what the cause is. So that's the best message when we do the screening because we really don't know more than that until we do a full diagnosis. So once we do the diagnosis and we know either they have normal hearing or they need medical follow-up or they've got a permanent hearing loss, the ones with a permanent hearing loss are the ones that need to get early intervention. And so that needs to happen before 6 months. That is based on studies that show that if we don't intervene by 6 months, we tend to have a more permanent delay in development. And so they go on, they get help from speech pathologists or other early intervention folks like Help Me Grow. They get hearing aids. If the hearing aid isn't enough, they may be a candidate for a cochlear implant, or they'll get sign language. So they need, some combination. Some babies have sign language, they get a hearing aid, and then they go on for a cochlear implant. So they get all of that. And that's great. The main important thing is that that baby is developing a system of communication because that's so important for all of their growth and development. Some babies pass their screening, but they have a risk factor for later or progressive hearing loss. So this is mostly babies that were premature and were cared for in the NICU, or babies that had a positive infection like a cytomegalovirus infection that's known as CMV. And CMV is the most common cause of developmental delay and hearing loss in babies. It's a very common virus. It's been around for a long, long time. So it doesn't get kind of the recognition that like COVID has or Zika has, but it can cause a lot of the same problems that Zika virus does. These babies can have small head microcephaly. They can have other neurodevelopmental problems, including autism. So that's why we want, if they don't pass screening early on, we want to make sure that they get a test to see if they've had an infection like CMV, because then they can be treated with like antiretroviral drugs or other treatments like that. Okay. So newborn hearing screening makes a really big difference. Before newborn hearing screening, we were only screening babies in the NICU for the most part, but by 2016, it ramped up really fast, and 98% of babies were screened at birth across the United States. So as a result, the age of identification has dropped really quickly. It used to be more than 2 years old on average when we detected kids with hearing loss, and that's for the ones we detected. We missed a lot of them. But now we're down to about 2 months in some states compared to the past. And these integrated EDI systems are really helping a lot to get the best treatment for the babies. But we still have a long way to go. It's not perfect. And this is something I've been working on a lot and trying to raise awareness, is that the critical component is that effective intervention needs to be made available and accessible. So 97% of babies are screened by 1 month. So that's like a good thumbs up. We're doing a great job there. The hospitals are doing an awesome job. But when it comes to diagnosis, only about 61% on average across the country are getting their diagnosis by 3 months. Some of them get it later, some much later. They show up at age 2 or 3, but we're only getting that early milestone for 61% of them. So we're trying to improve that, do a better job. We have a lot of loss to follow up, especially for some kids that are in rural areas, or they may be in poverty. They may not have access to health insurance coverage, which makes me really sad that we would miss that for a baby just for lack of having the insurance coverage. And then also some kids, it's like a language issue. They may not speak English in the family or really understand what needs to happen. So those are some of the reasons that we see that not all kids get followed up. And then when it comes to early intervention, only 31% are referred to early intervention by 6 months. So that's where we really start to say, whoa, you know, that's less than half of kids are getting what they need early enough. So we're really, most states are really working hard on this to try to improve those numbers for early intervention. So what causes hearing loss? Well, there's a lot of different causes. I mentioned genetic causes, that's more than half. There also are syndromes. So Down syndrome is a greater risk for hearing loss, cleft palate. Most of the syndromes that would affect the face, the head, or the neck will have some risk for hearing loss. And sometimes that's fluctuating hearing loss due to fluid in the ears or otitis media, or sometimes that's a permanent hearing loss. Some examples are Charge syndrome has a high risk for permanent hearing loss as one example. Waardenburg syndrome, which is like a white forelock, has a high risk. There's lots, there's hundreds of syndromes I could name that are associated with hearing loss. So complications of premature birth and neonatal infections, as I've mentioned earlier, are the other big risk factors. So how can you detect or be aware of hearing loss in a baby? Some of the signs are that they don't startle at loud noises. That's like a real red flag. That would be a child who has a more severe hearing loss. A little more subtle is that they might not turn properly to the source of the sound by 6 months of age. By 6 months, babies should be doing what we call localizing. You know, if you call their name or the dog barks or someone comes in the room, they'll turn accurately to go find where that sound is. So that's a really good indicator of whether they have hearing loss. They may not say single words like dada or mama by 12 months of age. And they may turn their head when they see you, but not if you call their name. So some kids with hearing loss are very visually aware, and they can fool people because they're really aware of where people are. And I've had parents like tell me, oh, they can't possibly have a hearing loss because I sneak into the room really quietly and they hear this little like footstep. And actually what they're doing is they're sensing vibration or even smells. You know, there's lots of other ways to tell that someone's there other than just hearing them. And then they may seem to hear some sounds and not others. So these are all kind of things that if you see that it's a really good idea to make sure that child has a hearing assessment. Hearing loss can be identified after a child passes a newborn screening. So the newborn screening is not 100%. Hearing loss can be acquired at any age, not just at birth. And these are some of the risk factors that could cause a child to have a hearing loss later on. And then, like I said, there's some syndromes or diagnoses that are also associated with hearing loss later on. Here in older children, here are some of the signs that you might see. So their speech may be delayed or not clear. I know that Maria is very familiar with lots of different speech and language delay. And sometimes the speech and language delay is due to other causes. It's not due to a hearing loss, but we always want to rule out hearing loss because that's a treatable cause of speech and language delay. They may not follow directions, and this can be thought to be more likely ADHD or autism rather than the result of hearing loss. So a child who's inattentive, not following directions is, again, that's something to look at. They often say, huh, or they want the TV volume turned up louder. Those are also warning signs in older children. So it's a hidden disability. We call it hidden because you can't look at somebody and know that they're deaf or hard of hearing. Up to 90% of the knowledge that little kids get is through what we call incidental learning. And so I put this little picture up there, little pictures. Has anybody, raise your hand if you've ever heard the expression, little pictures have big ears? Has anybody ever heard that? It must be this old Southern expression in my family because I always ask this and nobody ever knows it. But I heard this all the time when I was growing up. And what it meant was that there are little kids in the room, watch out, they might overhear what you're saying. We don't want them to hear, this or that. So it's kind of this awareness that kids will overhear, and a lot of what they learn is just incidental. It's not you teaching them directly, but just them absorbing and hearing what's going on around them. So the problem with that is that if a child has a hearing loss, they're not getting all that incidental learning. And it's also used for understanding our native language. So by 6 months of age, what's really cool is that when babies are first born, they have the potential to be a native speaker of any language in the world, any language, including sign language. But for spoken language, by 6 months of age, the brain is tuning in to the native language. So if a child is only exposed to English, their brain prefers English sounds, English phonemes. So that's why as we get older, we're less and less good at learning foreign languages. And after about age 7, we're really not great at learning foreign languages. We have to put a lot of effort into it. But if a child is exposed to, let's say, English and Spanish at birth, they will become bilingual. They'll learn both. And so they can also learn English and sign language. There's no reason that kids can't be bilingual. And in fact, studies that have been done have shown better cognitive skills in children that are exposed to more than one language. So I always say here in the US, we're very monolingual. We'd be much better off if we learned other languages early on. So that's a very interesting, I think, thing to know about. And the other interesting thing, I don't want to be overly dramatic here, but and actually I got this from Dr. Wiley. She used to say this, and it's really true. Childhood hearing loss is a neurodevelopmental emergency, meaning as soon as we find out about it, we need to do something about it. And the reason is that if we wait, the longer we wait, the poorer the language scores are going to be. So if you look at these graphs, just to kind of unpack them a little bit, on the left we have mild hearing loss, and then we have moderate and severe hearing loss. So the first thing you can see is that the more severe the hearing loss is, the poorer the language scores are. And the language scores are over here on the left side, going from 40 to 130. 100 is average, so that's where that gray shaded area is. And then you see the little individual dots, which are children. And so if they are older when they first get their hearing aid, that's the fitting age, then they have poorer language scores. And you can kind of see after six months, there are more and more dots that are below that average range. But even before 6 months, even with early fitting, it doesn't guarantee that a child's going to have normal language development. And like I said, about 40% of kids with hearing loss have other disabilities. So these may be children that have autism or have other, developmental delays that are associated with the hearing loss. But anyway, the earlier we fit children and get them intervened, the better the language scores are. And so some of the cost of delaying diagnosis are shown here. I mentioned earlier misdiagnosis, speech skills, reading skills. Reading is really intimately linked with language. And so if you're not a good language user, you tend not to be a good reader. Lower intellectual potential, lower adult earnings, and more limited social skill development. And you can see the chart over on the right. This is a good one to refer to. This has the hearing and language milestones that we expect by different ages. And when it comes to cost of educating a child with hearing loss, they're kind of right in the middle of other diagnoses. So if you look at this cost, this is per pupil expenditures by disability. Hearing loss ranks up there with intellectual impairment, with other health impairment, traumatic brain injury. It's lower than autism, but higher than speech language impairment or special or learning disabilities. So it is a significant disability when it comes to education. It's also more and more prevalent as we get older. So when we look at everybody at all ages, there are 30 million people in the US with hearing loss. And of these, only about 10% are culturally deaf. That would be what we call big D deaf, or they identify as being deaf and tend to use sign language. So that leaves the majority, 29.5 million, who aren't quite hearing and aren't quite deaf. So they're in between those worlds. The other disabilities that are associated with hearing loss are quite diverse. And you can see that the most common one is developmental delay, but cerebral palsy, autism are quite common. Visual impairments are quite common. This is why we recommend that every child with hearing loss gets a regular visual test, because that happens quite frequently. And to have a dual sensory impairment is particularly a problem. And so it's really important that kids get screened for these other issues. And then the other thing is that the age of intervention matters across all chronological ages. So there's kind of a catch-up that happens for kids that are less than 6 months old when they're first identified. So by the time they're 6 years old, they've caught up on average. But you can see that for all other degrees or all other like 6 to 12 months and so forth when they're intervened, there's a gradual catch up, but it takes a long time, up to 6 years of age, and they never quite reach that, completely average language. And also for all degrees of hearing loss. So we used to think that if a child had hearing in one ear, if they only had lost hearing in one ear, that it wasn't a problem. It would be sufficient for language development. We now know that's not true, that having a unilateral hearing loss also delays language in the long term, and mild hearing loss does too. And you can see that the gap between normal hearing, which is in the black, and mild hearing loss is the biggest gap. After that, you get an additional gap for moderate and moderate to severe, but even a mild hearing loss will bring down predicted language scores, so it's important to detect. Unfortunately, our newborn screening isn't as good at picking up the mildest hearing losses. So sometimes those may be missed and not picked up until a child is school age. And I'm going to now turn this over to Sam, and she's got some information for you on family counseling and treatment.
So as long as everyone can hear me okay.
Yes, it's good.
So if we strip away all of the statistics that Dr. Hunter gave and all of the numbers that make audiology seem really daunting, we get down to just kind of counseling the patient that's in front of us. And especially with children, we're not necessarily counseling our kids as often as we are our parents. So the first slide here I have is where I'm going to talk on giving a diagnosis to an infant or a newborn. And this is where like the true family-centered care comes in for audiology, because every parent and every family is going to react differently. It's important to note that about 90% of all of our kids who are born deaf are born to parents who have normal hearing. And so this is likely their first exposure to hearing loss and deafness. So they can be overwhelmed, they can be shocked, surprised. A lot of times our parents will go through the full grieving process. They will feel denial and anger and frustration and sadness. And it may take a while for them to accept the diagnosis. And that's true even in our kids who get diagnosed late at like 5, 7, 9, 10, where most of the time parents are unaware that there's even an issue with hearing until it's kind of brought to their attention. So the best thing we can do as audiologists is kind of understand that they're going to need their time to take in the diagnosis. At children specifically, I know that when we diagnose a child with hearing loss after a failed newborn hearing screening, we diagnose at an initial diagnostic appointment, and then we follow up with a second one to confirm all of our findings. And usually we find that the first one, there's a lot of shock and a lot of sadness and tears. And then the second one, once they've had time to sit with the diagnosis, they're a little bit more ready to learn about what the hearing loss entails and how to tackle it and get them into interventions and things like that. Go ahead to the next slide. So when we're talking about intervention for hearing loss, there are a couple of different options. Some families will choose not to treat the hearing loss as a medical diagnosis and instead go the more linguistic route and choose the deaf culture route with ASL. And Dr. Hunter will get into that a little bit later as well. But one of the most common options for treatment is hearing aids. Hearing aids are non-surgical, they're non-invasive. They're a piece of technology that for kids almost always will sit behind the ear with a piece that goes in the ear canal to amplify sound. And this is good for kids who have the mildest degree of hearing loss all the way to about a severe hearing loss. And it provides sound based off of their hearing loss prescription. So just like your glasses, you would go in and get tested and they would prescribe you a pair of glasses for kiddos because they can't tell us what sounds good to them. It's based off of a prescription. So a whole bunch of math goes into that, and we fit hearing aids based off of where they need amplification. So are they missing low sounds, high pitch sounds, and to what degree do they need that amplification? Go ahead and go to the next one. And then cochlear implants. So cochlear implants are a electronic device that is electrically stimulating the internal part of our auditory system called our cochlea. And so it's a surgical option, and it's meant for children and just people in general with more profound hearing losses. So this is for people who are more in line with the definition of deaf. So they don't have very much access to sound with regular acoustic stimulation. So just turning up the volume is not going to cut it for them. So an implant, what it does is it's a surgically implanted device that goes underneath the skin where there's a magnet, and then a small electrode array is threaded through the internal part, the cochlea. It's the snail-like structure here on the screen. And those little electrodes inside the cochlea will stimulate the different areas to get access to different pitches. So our high pitch versus our low pitch. It does not sound like traditional amplification, so it doesn't sound like an acoustic stimulus. It is a mechanical stimulus, so it's an electrical stimulation to the hearing nerve, essentially. And once the implant is in, then an external device is placed on the head. You can see that circular part behind the ear is using a magnet. It's kind of fixed to the head, and the external device has a microphone, a processor, and it sends that sound in via magnetic induction to stimulate that internal organ of hearing. And a cochlear implant recipient can hear much better than they can without it. A lot of times we can get them to the near normal hearing range with their electric hearing, but it does not sound like normal hearing. It does take a while to get used to. And I think that's it, because next we're going to see a video. Yes, there it is. This is a little guy, I believe his name is Cooper. And it's his family story of going from diagnosis to first wearing hearing aids to see if that provides any amplification or any benefit for him, and then moving on to their cochlear implant story.
Okay, I hope this is going to work because my mouse isn't letting me get over there. Yay, good.
I think you need to share your sound, Dr. Hunter. Dr. Hunter, this sound isn't playing. Dr. Hunter, are you able to hear me?
We can't hear the video, Dr. Hunter.
Oh, I'm sorry. Wait.
That's okay.
Okay, let's see. I'm gonna.
You might have to stop sharing and then reshare and optimize for sound and video, and then maybe allow some things to happen from there.
Yeah, my problem is that my laptop is not letting me go anywhere else. Oh, there we are. Now I can. Okay, I closed it on my laptop. Let me go to, need to do share sound. Okay. And do share. I think I closed out of. Okay. Are you seeing the PowerPoint slide?
So we're seeing the PowerPoint as an application, not in presentation mode.
Okay, let me do new share again. How about now?
That's it.
Better? Okay. All right, let's go again. Share sound is on. Okay. Sorry, we'll do a little backup here.
Elephant.
Also,
You wave to the workers. Say hi.
when he was born in the hospital, we did the newborn hearing test, and he failed both of those. But then everyone was like, oh, it's probably just fluid. And then we see a pediatrician at Boys Town, and they did another test, and he said, Ashley, I'm sorry, I'm probably not able to give you good news today. And so he referred us to see an audiologist at Boys Town, where we did an ABR, and he failed. Well, that's when we found out that he had the severe to profound hearing loss. It was devastating. We cried for a long time, not just that day. I feel like it was just really hard to even just like understand how this happened.
I was just in complete denial. I mean, that's all I thought. I mean, she took a hold of it really soon and she started studying. Me, I just kept on ignoring it, I would say, at first.
They said they were going to fit him with hearing aids at 4 months old. So that was our first step, and we were happy to do that. Still, it was hard to still believe it almost. And so we just kept seeing people at Boys Town, and then they said he's a candidate for cochlear implants.
I was still in denial. I mean, who could trust this little object going into a head, you know? And it's something scary. You don't want any surgery on your kid, but Boys Town does a wonderful job of just making it seem like it's a simple process and that it's something truly amazing.
The cochlear implant team and Dr. Kong kind of walked us through it, and they said, I do think that it's best that he has one hearing aid right now and his implant, and we'll keep watching him and see how he does. Make sure that he doesn't lose any more hearing in that year, but they think that it'll benefit him just being able to hear acoustically as well as with the implant.
By the end of the day, he was up running around like nothing happened. So, I mean, it was literally, I mean, other than us crying all morning while he's in surgery, after that, it was kind of a breeze and a relief. And then just seeing him happy after the surgery made me feel better. He didn't freak out when it was turned on. He just kind of sat there like, whoa, I can hear something, and you could tell it right away.
When we tried to get him to say the words that he knew before, I think it was a process just to relearn how he's hearing that. And so it takes at least a few months before we started seeing it.
Can you put the top on? Good listening, Hudson.
We meet with speech therapists at least once a week, and then we also go down to Boys Town to do speech therapy. And basically they're just training us as parents on how to incorporate all of this in our day-to-day life and how to talk with him and help him.
Sheep? Bah.
When we did our meetings of our goals, one of them was that he would say 50 words, and I was like, wow, like how is he gonna get there? But over time, he got there in 6 months and he surpassed that goal. He's 2 now and he can say, I'd say 100 words, so it's really exciting. He's putting 2 words together. Next year, he'll be going to preschool, so it'll be exciting just to be at school like a normal little boy and just participate in anything that he wants to do. 1, 2, 3. It's like the best decision that we've ever made. It's so emotional, it's so exciting. I remember how we felt when we were so unsure of everything and what would life be like. And now, I mean, we love it. We can't even imagine our life without it. We're like, this is the coolest thing ever. And it's the same for him. He wakes up every day and he wants to put it on. Like, he loves to hear with it.
Okay, there we go. So just any reactions to what Sam was telling you about the emotional part of learning about hearing loss? Did that surprise you, or the family story surprise you at all?
From a speech perspective, I have not seen this particular video before, but I've seen several that are very similar. And I haven't had the opportunity to work with any families with kids with cochlear implants, but I've learned a lot about it, and I was actually super interested in audiology before I decided to go into speech. And I feel like videos like this are just so helpful to show families because, you know, it's one thing for us to tell them, like, you know, there is hope. It doesn't, like a cochlear implant or a hearing aid does not mean anything bad at all. And it's a lot easier, I think, for them to understand that hearing from somebody else who's been through it. So I think that this is definitely a video that I'll save in case I ever do work with a family with a child with cochlear implant or a hearing aid. I think is just a great resource.
Thank you, Kelsey. It's a great insight about, hearing directly from other parents is always the most powerful.
Christy Gregg asked in the chat, is there any need for additional surgery throughout life or as they grow? And the answer to that is generally no. But sometimes there are revision surgeries that are needed. And when we have a piece of equipment in the head, we do always say that like contact sports are not a great thing for kids who have implants, just because anytime that there is like a trauma to the head, or it could displace the implant, and that could cause a need for revision. And I don't know the percentage right off the top of my head, but I know that I recently spoke to one of the ENTs at Children's who said that the percentage of having a revision surgery is quite low, at least through Children's. But it is a possibility, and so that's something we definitely go over, but they won't grow out of their implant necessarily.
Yeah, that's right, because the inner part of the ear, that little snail-shaped part, is pretty much adult size when we're born, amazingly. So when they put the electrode in, even if there are some implants that have been done on babies like 6 months old, which is pretty mind-blowing, but generally they don't have to be revised. And most of the technology changes happen with the processor, which is external. So there's regular software updates, and even the processor itself may be completely changed out. There have been a lot of like battery changes over time, with better battery life and recharging capability, and how it processes the speech to try to remove more background noise. But generally, unless the electrodes have a problem and stop functioning, and sometimes that can happen, that's called explanting or taking it out. Generally, it doesn't have to be. And there is a small number of people who, when they get older, decide they don't want the cochlear implant and they would rather live, with sign language and without hearing. And so they choose to have it taken out. But that's pretty rare, but it is possible. So it's good to know that. I know in the past, sometimes people in the deaf community would say, oh, I'm not going to get an implant for my child. I'm going to wait till they're an adult and they can choose to get it. And that sounds nice. It sounds really logical. And it's too bad that's not possible, but it's not, because of the brain's plasticity. The way that works is that if we waited until someone was a teenager or an adult, the brain just can't use that acoustic or that electrical input. And so there's too much dying off of the nerves that connect the ear to the brain, and it doesn't work well. Although we're going to be showing you another video of a girl who got a late implant and actually did pretty well with it, but she's unusual. Usually that's not possible. So
Shannon asked, is it okay for the implant to get wet? And the internal device is going to heal up, and that's, showering, all of that is a-okay. The external device, there are options to put covers on it and get waterproof options, but it's just like a hearing aid or any other piece of technology where it's water resistant, but it's not necessarily waterproof without the extra barriers that they provide. So like swimming lessons and things like that are things that come up with littles who have our implants. And so there are water aqua kits that we can send on with the implant. And then Christy asked, what is the latest age that they can receive an implant? And you can be implanted at any age. Generally, the earlier, the better for from a language standpoint, especially for kiddos who are profoundly hearing impaired. The earlier we can get them access to sound, the better that their language outcomes may be. But there's no, like, I've seen old adults, like geriatric adults in their 60s and 70s, get implants after progressive hearing decline.
When it comes to like school age children and kids in school, because I know there's like those systems that teachers can wear around their neck, and then it connects to a child's hearing aid and things like that. Do they have those for cochlear implants as well, or do kids with cochlear implants typically not need something like that?
there are FM options for kids with implants too, and they definitely would benefit from that. Realistically, anyone would benefit from having the speaker's voice closer to them, but especially our kids with hearing impairment. So hearing aids and cochlear implants do have the technology to connect wirelessly to get remote microphone information from like the teacher.
Okay, great. That was perfect, Sam. Thank you. Trying to get this to go on now. Okay. Do you want to do this one or do you want me to, Sam? This great debate one.
I can do it and then we can transition into the deaf culture.
Sounds
thing.
good. Okay.
All right. So there is a big debate on implants, which surrounds the kind of cultural definition of being deaf versus kind of medical ethics. So the hearing world versus somebody's identity within deaf culture. So deaf culture is what Dr. Hunter is going to get into in just a minute, but it entails somebody who has no hearing or a range of hearing loss who identifies as capital D deaf, which is different from just our lowercase d-e-a-f definition of deaf. And it entails being immersed in a sign language communication method and having a cultural upbringing that is conducive to their communication method. And being a part of deaf culture, there's a lot of pride associated with that. And so the great debate is that historically, people who are identified as capital D deaf had negative reactions to the medical model of hearing loss or hearing impairment, as looking at it as a true disability when they did not believe that they had a disability. It was their lack of access to communication that caused them to be disabled. So the hearing world doesn't necessarily cater to people who are deaf because we don't often have the means to provide visual language to them. And so it wasn't a them problem, it was the world around them. And they really kind of had these pockets all over the world where they had a community of people who were also deaf and communicated the same way that they did. There are some hubs in the US still. I know that like near DC, their Gallaudet University is a deaf education university and still subscribes to the capital D deaf culture definition of deaf and gives out classes in American Sign Language. But the big debate on implants was taking the risk of doing an invasive surgery to allow somebody to potentially hear again versus just kind of taking away the surgery that is invasive and just providing a means of communication that fits what they need. And so the debate is that medically, you are risking waiting surgery for delayed possible auditory development versus kind of giving them the language they want. But also if we think about it, like I said, most children who are born with hearing loss are born to hearing parents. So a lot of times people who are searching for treatments for hearing loss are people who grew up in a hearing world and were not exposed to deaf culture. So we also want to maximize the ability for these kids to potentially develop auditory skills and spoken language, while also understanding that there is still a cultural definition of being deaf. And that comes in with when we kind of tell people about their hearing loss. So we always give the options of there's an oral option of communication. We can do a hearing aid, an implant, or whatever is right for that kid's hearing loss, and also giving them the option of saying, well, sign language is also an option to give a visual to the language as well. And we also often will say that it's never a bad thing to expose even a hearing child to sign language because you're just giving them more means to communicate. But with implants, it's a debate versus kind of the medical definition of disability of hearing loss versus the cultural definition of being deaf and proud.
Jason had a really great comment. I'm so glad you brought this up, Jason, because it's a really important aspect that there's a Black deaf culture because of segregation based on race. A lot of times Black children couldn't go to schools that were for deaf and hard of hearing kids because those were segregated. And so this happens a lot in deaf communities where because of genetics, you can have a grouping of deaf people together, either in families or in extended families, and they'll create their own sign language. And so sign is very much gesture-based. That's where its origin is, and very pragmatic. And so the culture is quite different, and it's not the same as English. So if you're signing to someone who is in an English-speaking community but uses ASL. ASL is a totally different language, and we'll talk about that. But there are also dialects within, just like there are dialects in English, there are dialects in sign language. And so it's really cool to see all of the different regional differences in sign language. And Jason also mentioned disability advocates that use a similar definition for disability and impairment. So impairment's the biological piece. And as audiologists, we try not to use the word impairment, although hearing impairment is something we've always used. But really deaf and hard of hearing is the condition. And it comes from an impairment in the ear, but that's not the person. The impairment in their ear is not how the person necessarily identifies. Or I don't think anyone ever identifies as their ear. It's only a piece of the body. So this is probably, unless anyone else has any other comments or questions right now, it's probably a good time to take a 10-minute break. Our ears get tired of listening, our brain gets tired of listening. So let's go have a nice break and we'll see you back. Okay, I think we'll go ahead and get started again. We're going to start talking about deaf culture and the huge impact that education has had on deafness over time. And just to kind of start with just a general definition of culture, it's the integrated pattern of human knowledge, belief, and behavior that depends on our capacity for learning and how we give information to succeeding generations. So we pass on our culture to our children within our families and our neighborhoods that we live in. And this little graph on the right talks about some of the different important aspects of culture. You'll notice at the top of that's language. I think that's really cool that language takes that top spot, because a lot of people associate languages with particular cultures, and especially dialects within language can really tell you a lot about a certain subculture in a bigger society that uses one language. So I grew up in the South, and so my first, dialect was Southern Texas. And then my family moved to Pittsburgh, very different culture. And I found it hard to get accepted by the kids in my neighborhood in Pittsburgh because I talked weird. I had this weird Southern accent. And I was only 9 years old, so I lost it really fast. I became, I adopted the Pittsburgh dialect instead of the Texas dialect. And then when I went back to see my grandparents in the summer, my grandmother looked really wounded and she said, "Y'all talk like Yankees." And so I think that's just a really great example of how you can have this culture clash even within a family where they may not necessarily share the same culture anymore if they move or if they have life changes. And then when we think about deaf culture, of course, language is like a really big, huge part of that culture, is that the language is something that's shared. And so things like jokes are going to be different in sign language than they are in deafness, or they are in spoken English. You're not going to necessarily see that in things like clothes and dressing or religion. So deaf culture may have differences in subculture, like you can come from maybe a strong Italian immigrant family and have deaf culture, but then also have your Italian immigrant family way of eating, the foods that you eat, the religion that you have, the traditions that you have, the way that you dress is not necessarily the same as it is for other deaf people that share other cultural aspects with you. So it's a layered and complex sort of issue that's very interesting. And deaf culture is mainly based on American Sign Language or other sign languages in other countries as a distinct language. And American Sign Language actually came from French. So ASL has its roots in French, which is super interesting because there was a French educator who believed that deaf children in France could be educated and started the first school for the deaf in France. Before that, most deaf people were sort of restricted to learning trades, especially noisy trades. The idea was like, well, their hearing's not going to be damaged. It's a noisy place. They can work in that noisy place. So a lot of deaf people worked in print shops when printmaking got going, because that was an extremely loud industry that would kind of ruin your hearing. But if you were already deaf, it didn't matter. So that was kind of an interesting thing. And when schools for the deaf opened up, this allowed people to share their language, to have a shared sign language. Whereas before it had been very, very regional, and even within families, there had been individual dialects with gestural communication. So because a lot of people started marrying who met each other within schools for the deaf, you often then started to see families where both parents were deaf, and some of the children may be deaf too if the cause was in common. So it's not necessarily going to be the case. Just because you marry someone who's deaf doesn't necessarily mean your kids are going to be deaf. But the likelihood is that if it's a similar cause, then 25% of them may be deaf if it's recessive, 50% if it's dominant overall. So that can certainly happen. And so big D deaf culture that we've talked about a little bit is that pride about being deaf. I'm deaf and I'm proud of it and I'm going to say it, and I'm not afraid for people to know that I'm deaf. I'm not ashamed of it. I'm not trying to fix it. I don't want a cochlear implant or a hearing aid. Thank you very much. I'm very happy with sign language, and I'm very happy with my deaf community, and I don't need you to fix me, basically. Now, these are generalities, and there are people who feel all the way along that spectrum. I've met very, culturally deaf people who their baby was screened, didn't pass screening. The first time this happened to me, they came in, for diagnosis, and they didn't pass the diagnostic test. And I'm starting to go into that grief kind of counseling mode, but kind of reading them, and they were happy. They were just as happy as they could be. My baby's like me. I know what to do. This is not something that I'm going to grieve over. I know what this is all about. And so, that was a big culture shock for me, and certainly not what I had been trained as an audiologist. So it's really requires us to really open our mind and really think about what is that family's goals? How do they want their child to be educated? Not how I want their child to be educated. It's not my child. I'm not going to make that decision for them. It's really got to be something that's going to work for them and their family. And there are definite different decisions to be made depending on their cultural identity. So we're going to do a little role play. You've probably heard of lip reading. Has everybody heard of speech reading? Which basically speech reading means it's not all in the lips. It's not just what the lips do, it's what the eyes do. Lots of expression in our eyes. The whole face conveys language and emotion. In fact, the whole body does. We all are sign language users to an extent because we gesture with communication, we point, we do a little bit of, depending on if you're Italian or not, you may do more talking with your hands, but we all do that to an extent. So we're going to do a little bit of speech reading, and Sam has generously agreed to be our speaker. And she's going to do the usual thing that we've all done on Zoom, which is that we forget to turn our microphone on when we're speaking. So she's going to leave it off intentionally, and we're going to give you a topic. So we're going to give you a hint and make it easier. She's going to tell you what she did over her break, okay, for just a couple minutes. And what I want you all to do is to look at Sam's face and try to discern what she's talking about and any words or anything that she says. And we're going to make you guess what it is that she did over her holiday break. So take it away, Sam. Okay, I know she's finished, but that's all I know. I am just going to own up that I am the world's worst speech reader. I actually know what Sam did over her break.
Fostered 2 dogs from the adoption shelter.
Oh, Angel, that is amazing.
Nice. Yeah, very good.
Woo!
Something about maybe you hung out with your friends with the 2 dogs.
That's really impressive. I had my friends over for Christmas, and I fostered 2 dogs from the animal shelter. Both of them got adopted before break was over. That's all I said.
Anybody else? Raise your hand if anybody else got any of that. Angel, did you know you have this hidden talent?
I did not know. I did spend a lot of time trying to read lips with my parents. They were really in on this, like, little kids have big ears.
Ah, there you go. All right. They trained you to be an awesome lip reader, speech reader.
I'm impressed because the goal of the assignment was to say how hard this is, and you nailed it.
You made it look easy. Okay, how about some reactions from anybody else? What did you feel? What was going through your mind as you were trying to understand what Sam was saying?
I think for me, I've never worn glasses before until I hit a certain milestone birthday, and then I had to start wearing reading glasses. But I did everything to try to make the PowerPoint smaller so that it made her bigger. but I couldn't get it. So therefore I couldn't really hone in on her face because she seems like she was far away. And that's how it is for me now with needing glasses, like for things that are closer or smaller or close up. So if I could have just made her bigger, I kept thinking, so, and that's what I kept feeling. I kept feeling, wow, this is all a part of my vision changes as I get older because I can't see her as well. So that's what was difficult for me. I was focusing more on the fact I couldn't see her hardly at all.
Patricia, do you find it harder to hear now that your vision has changed? Because I've always had, if I'm not wearing my glasses or contacts, I can't understand what people are saying. So I know I speech read a little bit, but it does help.
Yeah, no, because I never wore glasses until, around age 40 is when your changes start to take place and you need reading glasses. So, and actually, and still, and I won't say how old I am, but I still only need it for reading. So, so actually, no, my hearing is fine. I just, I can hear you. I just if you're close up on me, I have no clue what I'm eating. So I have to put my glasses on so I see what I'm eating, but I can hear fine.
Yeah, it's more I meant that harder to understand because you're not getting as many visual cues. That's what I've always found is that if I don't have the visual cues, it's harder to understand people, especially in noisy places.
I think that this happened to me when we first started wearing masks. I remember sitting in a lecture and thinking it is harder for me to understand. And I didn't realize I spent a lot of time looking at the person's face, especially mouth, like lower half, as part of like the cognition process.
Yeah, it's really cool.
Such a weird phenomenon. So I was going to ask, is that has masks been kind of a barrier in terms of deaf culture of
huge
this
barrier?
Whole, yeah.
Huge barrier. We did a little study on it at Ohio Valley Voices, which is the school for the deaf here in Cincinnati. And we recorded how children were able to understand with different sorts of masks on, and the masks definitely brought down their understanding, even with their hearing aids and cochlear implants on. And if we use the clear masks, do you guys know what the clear masks look like? They did better, not as well as with no mask, because the masks also change the sound quality. So those clear masks make it a little bit muffled and harder to hear. So they didn't do as well as with no mask, but having the visual input definitely helped them. Anybody feel frustrated trying to hear? Yeah, it was definitely a hard assignment, I think. So this is what deaf people deal with every day when they're trying to talk to hearing people who don't know sign language. They are trying to get everything through visual cues, through lip reading. My grandfather was actually deaf from a young age, and he was a phenomenal speech reader. But still, when it was a topic that he wasn't familiar with or a speaker he wasn't familiar with, he really struggled. And we know he was only getting little bits and pieces and having to put that all together in his brain. So it's definitely difficult. So the next thing I'm going to show you is a little TED Talk by a young woman named Heather Artinian, who is a deaf woman, and she's going to tell you her story. And I'd like you, as you're listening to it, to kind of reflect on the idea of building bridges in your world. That's what her story is about. And there should be closed captioning because her speech is a little bit challenging. Can you hear it okay? Okay.
Hi everyone, can you hear me well? Yeah, okay. My name is Heather Artinian.
Pause it because I want the closed captioning to be on.
I am really excited to be here.
Let's see, I had it on when I saved it. Annotations. There we go. We'll choose English. Sure. How about that?
Part of you all today. I want to start off with a question. What world do you belong to? because that's a question I get all the time. And my answer is always, they had a world. Today I want to tell you about how I got to the head of the world, and I sincerely hope that what I'm about to say today will help you understand better why you should build bridges between the worlds of your whole lives. I was born very deaf, which means I could not hear anything but a topic bomb, which would be useful. I'm thankful for that. Otherwise, I get a peaceful night's sleep every night without fail. This is awesome. My family is deaf. My parents are deaf. They're also culturally deaf, which means they communicate using sign language. They work in deaf schools. They have deaf friends. They are just totally immersed in that world. I have 2 younger deaf brothers who are the same way. But I also have hearing grandparents, hearing uncles, deaf aunts, deaf cousins, so my family is just a giant mix of hearing and deafness. But I love, it's my favorite part of my family. When I was 5 years old, I was standing on a bridge, and to my left were my deaf parents and the deaf world, and to my right were my hearing grandparents and the hearing world. I was just 5 years old at the time, and I desperately wanted to be to be equally in both worlds. And that's how the controversy started. The documentary came about because I decided that I wanted a cochlear implant, which is a device that helps me hear. And my deaf parents and the deaf world were very critical because they felt like I was saying that the deaf world was not good enough for me, that I was rejecting my parents' whole life, which was not the case. But then we got criticism from the hearing world as well, because they looked at my parents and said, why would you give your child the opportunity to hear? Complicated question, right?
Sorry, just because I muted it.
And that's how it started. At the end of the movie, after all the fighting, my parents ultimately decided that it was the best choice at the time for me not to get the cochlear implant. So I was once before in the middle of the bridge, but now I was totally immersed in the left side, the deaf world. We moved to Maryland, which is a huge deaf community compared to where I was living before in New York. You went to the Blockbusters, restaurants, the grocery store. It was easy because they were very aware of the deaf world. They knew how to interact. I remember being back home in New York where my parents were sitting in a restaurant. It was such a struggle just to order drinks. There were a lot of words, hush, pretty, oh, no, I didn't order this. But in Maryland, the servers knew what to do, and my brothers and I went to deaf schools. My parents were visibly happy. But then we lived there for about 3.5 years, and my mom got really sick. So we had to move back to New York. And I was put in front of the hearing world again. Kids on my block, they all spoke, they all did this side. And I remember looking at them, and I wanted to communicate with them, I wanted to play with them. I was 9 years old at the time. And for a while, I did not want the cochlear implant. I desperately wanted to move back to Maryland, move back to that comfort world that I know my whole life. But after a while, especially after my dad got passed over for promotion at work because of that, I could not communicate. I realized I did not want that for my son. I should do it. And I really want to be able to communicate with just anybody. So I decided, at 10 years old, I was going to get the cochlear implant. And my parents said, okay. My doctor told me that the results I would get would be very minimal because I was 10 years old and that was past the language learning stage, that I probably would not learn how to speak or hear very well. But I wanted to try. Who knows, right? Maybe it would work. And I think that it did. I got a better at hearing and better at speaking. right from the beginning, I went to hearing school, and I had no speech skills, no listening skills. People could not understand me. They would just sit there and nod. I have no idea what you're saying. But that's okay. And throughout that time, I was still going to speech therapy. Then I got to high school, and I realized that my speech and hearing was getting better. People were starting to understand me, and I was starting to understand them. And I also played sports, which was my way in, because people saw past the hearing or the lack thereof. They saw me and they thought I was good at sports, so they wanted to be my friend. That was my first opportunity that I saw to bridge gaps. What I would do is I would go to school, then I would go to my clubs and activities, then I would go to my practice, my soccer practice. I would come home at 9 o'clock at night, go straight to speech therapy, and then after that, I would do my homework. I did that every day, right up until I graduated. It was a lot of work, a lot of dedication, but I was willing to put in the work, and I saw the results. I did not do all this myself. I had a lot of help. I had speech therapists who put up with me every night. I had interpreters in the classroom who helped me when I couldn't understand. I had a wonderful family who supported me through all this. When I was 16, my parents and my brothers moved to Rochester, New York, which has a large deaf community just like Maryland. I stayed behind and I lived with my grandparents because that was the best decision for me at the time, because I wanted to keep on doing what I had been doing all along, going speech and just building the bridges with people. And this is more pictures of my family. Here are my uncle, my aunt, my wonderful grandparents, and my other uncle and cousins. I fast forward to today. I am a junior at Georgetown University. I major in government, minor in justice peace studies. I'm at my dream school. I have dreams of going to law school, and hopefully, like everyone else in Georgetown, becoming a Supreme Court justice. Who knows? Maybe. After high school, I realized one thing. I didn't have to be in the hearing world. I didn't have to be in the deaf world. I could just stay in the middle and be my own world, the heather world, which is a mixture of all kinds of experiences I've had, be it that living in the hearing world, having cochlear implants. I have 2 now, by the way, I forgot to mention. Which brings me to my idea. I really strongly believe that we all should grab the opportunity to bridge the walls within our lives. Whether your experiences are small or big, you can do it. I've learned through my experiences that when people seem mean or they seem standoffish, it's not because they don't like you. Most of the time it's because they're scared and they don't understand. All they see is the depth and they don't see the heather. So it's my job and it's your job to reach out, try to build a bridge over that. So what I'll do, I'll introduce myself and say, hey, I'm Heather. I'm deaf, I know. But I have cochlear implants and we communicate just fine. If you don't understand me, I'm happy to repeat myself. And trust me, my roommates do it all the time. And you see the difference, people start realizing, oh, just normal, I could just have a conversation with her like everyone else. They become more comfortable, which is the key. People are uncomfortable when they see new things. And I think it's our job as human beings to reach out. And this idea can be applied to a variety of different things: race, gender, disability, politics, access to education. Reach out, and you'll be surprised. I really believe that all of us have experiences, regardless of how big or small, it will make an impact. Just by me reaching out to one other person about my deafness, that person will probably become more comfortable around other deaf people. And those people will probably become more comfortable around other things because they've tried new things. And I really feel like once you bridge and you open yourself up You help them understand why you're worth building a bridge over. You are, we all are, but when you open yourself up, they understand and they will try most of the time. I met my best friend in high school, and in middle school, I was very shy. I didn't reach out to anybody. I was just staying in the corner and saying nothing. But when I got my confidence in my speech, I started reaching out to people. And just by me reaching out to this one person, she's now studying sign language. She's fluent, almost fluent, studying speech pathology, and she hopes to serve the deaf community after just meeting me. So you can do that too, just by you reaching out about your experiences. You could make a change in someone else's life. But sometimes people don't understand. I remember talking to this one person, and he would say to me, "So where are you from?" I said, "Oh, I'm from New York." And I, no, really, where are you from? I'm like, New York? They're like, no. I hear the accent. Where are you from? And I'm like, oh, I'm deaf. And they're like, no way, he's speaking right now. Where are you from? I said, okay. You're right, I'm from Africa. That's where I'm from. That's where I get my accent. So sometimes it takes more effort than you think. But that's okay. But other than that, you will also get a negative reaction. Building a bridge is not one-sided. You need the other person to be willing to come to you. And I've come across many situations where people say to me, "Heather, why even bother going to law school? How are you even going to communicate in the courtroom?" Or I've had people laugh at me and disregard my opinion because they think I'm dumb and dumb. Or people look at me and all they see is the cost of the interpreter. But here's what I say to those people. It's okay. It's part of human nature. People will have their beliefs. But what's important is the bridges that you do make with people will make up for those. Those bridges that you make will move society forward. And as you build the bridges, those numbers will grow. And the numbers of those who didn't believe you will grow smaller. And I'm telling you, when I get my diploma from law school, I kept a list of all the people I've been emailing them. My diplomas. And they will be signed. This is the example of a bridge I made in college. My roommates are the best people I've ever met, and I've never met them if I didn't have the courage to reach out. That was just my little shout out to the most awesome people I know. Shout out. So my conclusion is, I'm standing in the middle of the bridge. I'm understanding, really, that I don't have to choose what world I'm in. I can be the head of the world, and so you can have your own world. Who cares what anybody says? I think that we all should reach out, build bridges, be your ripple effect in the world. And I think you will be very surprised at what you will find at the other end of the bridge. So reach out, allow other people in, try to understand different experiences, allow others to understand yours. No matter what the experiences are, positive or negative, you will make an impact. Thank you.
And I would love for Heather to be a Supreme Court justice someday. I think she would really help that body. So just have a couple of kind of reflection things for us to think about. Darn it, if I can get, there we go. Thank you, mouse. Stay there. Oh, it keeps going back to my laptop. Okay. There we go. So why do you think Heather felt like she was literally between two worlds as a deaf person using cochlear implants? Does anybody have any ideas about that?
I do, a little bit just personally as an autistic person and being between autistic culture and neurotypical culture and trying to navigate in some ways to get what's meaningful for you from both cultures in some ways, but also being told that everything that you're doing is wrong, or, you know, it doesn't help, or that your impact on that is not helpful, because, you know, if you trying to find a middle ground or trying to navigate between things, sometimes, especially now, but even just within different identities, can be really, really tough. And a lot of people hold multiple identities even with that. I mean, people do that within even disability and race and other sort of things, of being able to navigate multiple spaces and being able to be authentically who you are, and feeling like you're being met, and sort of that you can accommodate others, and that others can accommodate you or know you.
Yeah. Oh, please don't apologize, Jason. That's really so insightful. Yeah, you want to live in the Jason world, not someone else's world, right?
Yeah, and I want the Jason world to interact with other people in a meaningful way, so we can both sort of, you know, get to, you know, ways that we can both meaningfully engage with each other in some ways.
Thank you. Thanks a lot. Anybody else have other thoughts about that, or bridges that you want to build, or that you are building in Lund with worlds that may not be as familiar to you or as comfortable? Feel free to put it in the chat. It's always a little bit intimidating to have to come up with something like that off the bat, but if you think of something, please feel free to put it in the chat as we go on. Okay, there we go. All right. So education has been something that has sort of been put upon deaf people from the beginning. You know, I think the original idea about providing education, trying to bring deaf people into the world of education and not sort of relegate them to a certain trade or profession, was a really good thing. And then it kind of went in different directions. And for a long time, there was a big kind of push and pull between what was called manual communication, and oral education. And so Gallaudet University came out of that tradition of manual or sign language education, because of course this was before the days of hearing aids or cochlear implants. These children didn't have any access to sound. They're not going to learn to speak. They need sign language to be able to communicate. But then we had other universities, and so it's interesting, Gallaudet is in Washington, D.C., and the National Technical Institute for the Deaf, which came along later, is in Rochester, New York. And so it's interesting that Heather's family moved there, because that is a much stronger like oral tradition. And there's also Clark School for the Deaf in Massachusetts, which, you know, did a lot of oral approaches. And it didn't work for most deaf kids, you know, because they didn't have access to sound. They couldn't learn from just speech reading or from lip reading. They couldn't communicate well enough to really be able to learn, and to learn to read especially. And so there was a report in 1965 that said oralism is a failure. This is not working for deaf children. And so that helped to shape the first public law that provided special education funding for children who were deaf. You know, the term that Heather used, deaf and dumb, was a very common term when I was a child. It really was. It was equating people who were deaf with being low in intellectual ability. And those are not the same thing. Those are different disabilities. And so total communication arose out of that in the 1970s, which was to combine together both manual communication and spoken communication. Because remember that people aren't necessarily completely deaf. They may have some degree of usable hearing. And so we really need to be able to really approach it from that whole continuum, because every deaf person isn't the same and doesn't have the same abilities. And then later on, there was a recognition that even with oralism that worked or with sign language, there was this gap in that deaf children had very low reading skills. So the average deaf child would graduate from high school at a 3rd grade reading level, which is functionally illiterate. And the reason is that if you're using ASL, it doesn't translate to English. So you really need to be bilingual. You need both ASL and you need English to learn the phonemes that go into English, written language, because there's no written version of ASL. So or signed English is a way to try to exactly put in things like plurality, the S's, or the ED for past tense, which ASL doesn't have. And so it's a way to try to help deaf people become better readers. And that's actually what I learned when I was in graduate school. When they said sign language, they were actually teaching us signed exact English. So I would add an S, for plurality, or an ED, literally, for past tense, which is not in ASL. And then finally, the Individuals with Disability Act, when that came in, and that led to the least restrictive environment to educate children, it was recognized that residential schools for the deaf were too restrictive for most children, and those began to close. And most parents of deaf children wanted their kids to be able to be educated in their neighborhood schools. So the transition here is that in the 1940s, most deaf children attended residential schools for the deaf. There was a transition period in the 70s where more kids started to attend mainstream schools. And by the 2000s, the majority of kids were mainstreamed and only a smaller proportion were attending special schools. So schools like St. Rita School for the Deaf, which we have here in Cincinnati, or Ohio Valley Voices, are examples of special schools. And there are also some programs within neighborhood schools, like Pleasant Ridge Montessori has a classroom for children who are deaf and hard of hearing within the regular school. And those are generally kids who need interpreters, or they need more help than would be available to them otherwise. So there's also a move now toward bilingual, bicultural deaf education. And this is an awesome website that's actually out of Canada that recognizes that this is both the native sign language of the deaf community as well as the majority language. So children learn both. And we know that kids are capable of learning bilingually. It also includes a lot of respect for one another and different cultural differences that may have to do with ethnicity or race or socioeconomic status. The kids are taught to collaborate in decision making, and they're taught about advocacy for their rights, so the rights of deaf children and adults within the larger community. And so this really gets us to this idea of work within a village, which is a part of the EDDI programs. And the EDDI National Conference is going to be in Cincinnati. So I'm super excited about that. It's going to be in March. And we're actually going to have tours that will come through Children's and over to DDBP. So if you're in speech language or PT or OT, we're going to kind of focus on deafness plus other disabilities, because Children's does such a great job of interdisciplinary care for kids that are deaf and have other disabilities. And if you're interested in being a part of that tour and helping over in the medical office building, it'll be on Wednesday morning, March 16th from 9 to noon. And barring any cancellations due to COVID, we hope not, that's when it'll be happening. So if you're interested in volunteering, you can use that for some of your service hours. So just let me know if you have that interest. We're kind of getting, I wanted to leave a little bit of time for questions. So just kind of a summary about, developing communication is really the key. And doing that, the earlier, the better, we get better outcomes for kids. And so whether that's through manual communication or spoken communication, we've really gotten away from this idea that it has to be one or the other. Different choices are right for different children and for different families. And we want to make that entire array of choices open to kids and to help families in their journey of choosing the right, intervention path for their child. And that's really what it's all about in the end. So I really want to thank you all for being here today. There are some optional handouts on today's module from Gallaudet University And if you're interested in things like special education and how do you come up with IEP goals and transition planning and some of those more in-depth sorts of topics, some of those handouts you might find helpful. So please have a look at those as well. And if you have any questions for Sam or for me, we'd love to hear it. And I know there's a few things in the chat as well. Thanks, Kim. I'm glad you liked the video. I love that video. I just think she's an amazing woman. And Colleen has been learning sign language online. That's great. That's so cool. So if anyone's interested, multiple deaf people have recommended Bill Vickers on YouTube as a good ASL teacher. Thanks, Colleen. That's fantastic. Does anybody else have any thoughts about the video or anything we talked about today that you want to share, or any questions that we haven't covered? Okay, well, I hope this was interesting for you and that you learned some new things.